Good evening. Welcome to ODISHA Live, Conquering Complex Coronaries Day 2. Yesterday we had a very good case from Apollo Hospital, followed by some lively discussion with a few cases. Today we have with us the live case from Care Hospital, Bhubaneswar, which will be done by Dr. Mahendra Prasad Tripathi and Dr. K.C. Misra and his team. I would like to introduce my co-moderator, Professor Shubhra Banerjee. He is Senior Consultant Interventional Cardiologist at Apollo Multi-Speciality Hospital, Kolkata, with decades of experience in intervention and a very eminent teacher as well. I also have the pleasure to introduce the expert panelists for this session. We have Professor Dr. Saidur Rahman Khan from Bangladesh. He is Professor and Senior Consultant, Ibrahim Cardiac Hospital and Research Institute, Dhaka, one of the senior most consultants in Bangladesh and a pioneer in radial intervention. He is faculty in many major cardiology conferences across the world and has done many live case demonstrations in international conferences. He has numerous publications across journals under his belt and is a pure academician. Welcome, Professor Rahman Khan, to ODISHA Live. We also have Dr. Ashok Kumar Parida, who is presently Vice Chairman and Senior Interventional Cardiologist at Health World Hospital, Singapore. He has numerous publications in national and international journals and is a very eminent cardiologist in West Bengal. Welcome, Dr. Parida. We also have Dr. Devashish Ghosh, who did his MBBS from Bardhaman Medical College, and MD from Kolkata, an MRCP from Royal College of Physicians, UK, with 2 FRCPs from Edinburgh and London, and FSCC from USA. He has long-time experience as cardiologist at UK, as well as in different reputed hospitals. Currently, he is Senior Consultant Interventional Cardiologist at Multi-Speciality Hospitals, Apollo, Kolkata. We also have with us Dr. Neerab Kumar, who is probably joining up. His current position is Additional Professor of Cardiology and Senior Consultant Interventional Cardiology at Department of Cardiology, IGIMS Patna. We also have Dr. Lingaraj Nath, who will be joining very soon. He is Director and Senior Interventional Cardiologist at KMRI Hospital, Bhubaneswar, one of the most senior and very reputed cardiologists of Bhubaneswar, associated with many associations and have many publications. I wish to introduce Dr. Mahendra Prasad Tripathi, is head of the department and chief consultant interventional cardiologist at Care Hospital, Bhubaneswar. Is one of the most eminent and senior interventional cardiologists in Eastern India, with close to 40 years of experience. After his DM cardiology, he has completed his fellowships, and he was a fellow in cardiac pacing and electrophysiology and interventional cardiology at University of Rouen, France. Dr. Tripathi has also worked as a lecturer at SCB Medical College and a great teacher too. He was the first to start interventional program in Odisha in 1997. Welcome, Dr. Tripathi, to ODISHA Live, and we are looking forward to your live case. We also have with him Dr. K.C. Misra, who has done his DM cardiology from SCB Medical College, Cuttack, and currently with Care Hospital, Bhubaneswar. He will be the co-operator, Dr. Mahendra Prasad Tripathi. So I hand over the podium also to my co-moderator, Professor Shubhra Banerjee. Shubhra, over to you.
Thank you, Dr. Dev. I think we also have with us Dr. Sharat Kumar Shah, who is a very dynamic cardiologist from Orissa. And Dr. Tripathi, are you good to go? Nice to see you.
Yes,
Great.
yes,
So, yeah, over to you, Dr. Tripathi. Would you like to give a brief history and show the angiography?
Okay. So, good evening, everybody. So,
could you be a bit louder?
okay, Dr. Binayak Dev, I think is my colleague. So he has given a good introduction of mine.
Can you increase the volume, sound volume a little more, Dr. Tripathi?
Just a minute.
It's good now.
Okay. So thank you, everybody. So good evening. So Dr. Binayak, please sound a bit less. Sound. So thank you, Dr. Binayak Dev. He is my colleague and also the esteemed panelist and moderator. So I am thankful to the organizers for giving me this scope for giving a live demonstration. So this is the case. So my the co-operator is Dr. K.C. Misra, and they are all my staffs of the cath lab, and the chief technician is Prakash Jana. So this is a case. I don't think this is a very, I think, promising case. Whatever may be, for the sake of any case, which I think is difficult and also simple. So he's a 61 years male, admitted as a case of severe retrospinal chest pain, and he had non-STMI, is non-diabetic and non-hypertensive, and EF was 50%. So on coronary angiogram, which was done yesterday, he had distal arterial lesion and of 90% and mid-LAD calcific lesion. The PTCA to distal RC was performed yesterday, 27th, and because of moderate to heavy calcium of the mid-LAD, so I plan for a OCT imaging plus minus rota guided PTCA to LAD. So this is the case of today. So I think the angiogram picture, can you show? This is the yesterday's angiogram showing left coronary injection, the co-dominant L6 system, and you can see the mid of the LAD. There is a calcium, I think moderate to heavy calcium with approximately 70 to 80% of narrowing. So this is the left coronary angiogram, and right one, please. I think it is disease from mid to distal, minor disease up to distal. At the just prior to the crux, it is 99% occluded. So yesterday I did a PTC stenting to distal RCA, and today I plan for a PTC stenting to LAD with rota. Any comment from panelist or moderator?
Professor Rahman, would you want to comment on this case? Please unmute yourself.
This is Dr. Devashish Ghosh. Just a quick question. Why didn't you attempt it on the same sitting?
Okay, because the creatine was little borderline, so okay. I planned it today.
But if your creatinine was borderline, I think the advisory is that you postponed at least for 3 days. I think that is.
It was around. It was 1.2, 1.3, 1.3.
Okay.
Yeah. Another thing we may add is probably may not be in this case, but the creatinine is borderline a bit high. Then probably IVUS could be a more suitable alternative to OCT. Just I mean, I don't know what the creatinine is after doing the first angioplasty. If it has gone up, then probably that could be a little bit problem for the OCT.
I think you mentioned it as 1.2 or 1.3.
That was before the first plastic, or is it after the first plastic? Because normally, see, as Dr. Ghosh said, the creatine takes a couple of days actually to go up. So because it's been done yesterday only, we don't know what the creatine is now.
So I is a non-hypertensive and non-diabetic, so this is just a borderline. So I don't apprehend that it will go more. Still, then, but difficult to say. With contrast, it may go also. But today's it is normal, and as you have pointed out, it usually goes up in the third day. So IVUS would have been preferred over OCT. I agree with you.
Yeah, I'm Dr. Khan.
Yes, Dr.
because we are
Karan.
dealing with this in a diabetic, in a diabetic patient. Actually, we are in a diabetic hospital like ours, so all the time I'm facing these problems. Actually, that what we'll do, because 3 days if you keep the patient in the hospital, that is also a burden for the patient itself. The cost is the issue. Obviously, 48 to 70 hours is the peak time to be increased. That is also true. But at the same time, sometimes we do that one, like Dr. Devashi, he is doing now. Possibly the ejection fraction is not that much impaired initially, and because you can give lots of hydrations there. And in that case, sometimes you may not need to wait that much. And if the creatine is borderline, not like, moderate CKD or severe CKD or something, it's like a mild CKD, then we can go for these things off level. Not, I'm telling, appropriately, if you do tell that one, obviously OCT would be avoided if you say, but you know that even in case of OCT also, not that much contrast, maybe 10 cc or 15 cc more than an IVUS, isn't it?
Okay.
Okay.
Okay. Thank you.
Yeah. So what did you do, Dr. Tripathi, after this?
So then after this, I did a OCT run. I think this I'll be showing. So we show the calcium score is up around 4, and the distal diameter of the vessel 3 millimeter and proximal 3.5, and length of the lesion approximately 28 millimeter. Then let me show this one, then I'll tell what I did. Okay.
Yeah.
Okay, please focus on, I think the calcium arc, or the maximum calcium arc, and also thickness of the calcium, and so the length of the calcium. So the length is coming approximately 8.8, and also thickness is coming approximately 0.4, 0.86 thickness, and arc is more than 100. How much? 170? More than 180.
Yeah.
So according to Fusino's classification, it's not that much severe, right?
Yes, yes, right.
The other interesting feature was there's no calcium spicule or nodule, which would actually make you choose a rota. Actually, you can also think of other calcium, more simpler calcium modifying therapy. There's no nodule. The arc is okay, circumferential, but it is 180, and the thickness is also actually not that much. So
yeah, but if you keep the Dr. Devashi, if you keep the figure here, you see the figure here.
Yeah.
On you see at 3 o'clock position, there is something there. You see, there is some density just beneath the endothelium. What is that one? You see, there is ectopic density there.
Yeah,
and which may create some problem, because malapposition or under expansion there is also a question there.
Now, if you look at calcium modifying therapies here, your choice between the simplest is basically a high pressure balloon or a cutting balloon, or say scoring balloon. So that is the simplest thing. It saves money and it's the most simple therapy. Yeah. So that is one choice. The second choice is obviously an IVL therapy, and the third choice is a rota. Now, the advantage of rota is especially if it is a very tight lesion and you don't think any balloon is going to cross. So that is the number one indicator of whether you will actually choose rota pre. The other very important thing, rota is very, very good for proper calcium nodule, if you see a nodule sticking into the lumen. So these are the two things which will make rota your deferred, absolutely your preferred choice. If you see the other features, I think you can think you can have all the things. At least think about them. I'm not saying rota is a wrong choice. But I'm think you can think of either with a scoring balloon, or and if that opens it up, I mean, that makes the procedure so simple. And IVL is expensive, but again easier to use. That's so I think all the therapies would be pertinent here.
What did you do?
To go for a step by step.
Yeah.
I think better to go for step by step, like using the scoring or the cutting balloon, and let's see and do the IVUS again, and let's see how much the cracking of the calcium is there by these modifying balloons. And then later, I think even by OCT, it seems like that he may not need a rotablation if IVL is there.
Yes, Dr. Tripathi. So, how did you proceed?
Yeah, I partly agree with you. So this is not very heavily calcified lesion. So this will be at least maybe intermediate lesion. So I agree with the panelist. So rota, I think, is reserved for maybe in crossable lesions where balloon cannot be crossed. So but maybe so once you take a balloon, and if you cannot cross, or if use a open-NC balloon, if there is eccentric balloon opening, so in that case you will be in trouble unless you have got a IVL. Unfortunately, we have not IVL today with me, so I have taken this choice. So otherwise, IVL, I think the last choice is the best one. So if it doesn't open with open-NC, I agree with the panelists. The choices what has been discussed, I fully agree.
So how did you proceed after this?
So then I did a rota run with 1.5 mm burr, and there's no difficulty in that. So after that, the angio picture after that, please show. Okay, so I have taken a regular coronary guide wire, and now I'll dilate with a no need for a scoring balloon. I think I'll dilate with a usual balloon, not scoring balloon. Or any opinion? Shall I take a scoring balloon or cutting balloon or any regular balloon? I think
Dr.
any regular
Parida,
balloon.
your opinion, please.
Regular, okay.
Dr. Nirav Kumar, any opinion from you? Okay, Professor Khan, can you give your opinion, please?
Just the cutting versus scoring is a it's a dilemma. It's still there's big questions. There are those who love cutting balloon, especially the Boston one nowadays is Wolverine, and is a beautiful option maybe. But at the same time, I love scoring in that for that purpose that it has least melon seeding effect. And obviously it is I like it for different reasons, like not to perforate the vessel. This is easier, and you can test that one, and if it's not working that way, then maybe the cutting balloon may be another option from my part, because it's it depends on the availability, and also how much you use which one. That is also another.
So, Dr. Tripathi, did you do a OCT run after this to see how much calcium you have broken?
Okay. Shall I take one? Okay.
Yeah.
Okay, thank you. Give me the OCT.
You agree, Dr. Banerjee, that we should do a OCT after this?
Yeah, I mean, of course, we have to keep in mind that we can't have too
I know,
many
yeah, about the
runs.
creatinine stuff, you know. Yeah,
but otherwise, maybe a quick run of that area.
Actually, if I wouldn't do an OCT here, I would just test the lesion out with a balloon. Even a simple NC balloon would be all right, because if this NC balloon gives away and dilates up, actually the rota has done its job. And I think that's the simplest way to see whether you've really modified the plaque instead of taking dye and getting a run again with a OCT. I would leave the OCT for, again, you have to do the OCT post-procedure. So there will be dye involved there as well.
Yeah, I think that's a good point, actually.
Okay, I'm taking the OCT.
Dr. Devashish, yeah, it's at one end it's a good point, but from another end you have to take the balloon is 1:1 to check really that whether it's expanded or not. And you know that before rota, what we have seen by the OCT, the distal reference diameter, by that way you will have to choose the 1:1 balloon, because that is also very much important, because sometimes we are not that much optimistic to take a 1:1 NC balloon. It's, you know, that being a little bit afraid of that one, that how much I will expand it or how much. And also you have to take, after inflating the balloon, you have to take multiple views, multiple orthogonal views to see whether that the balloon has been expanded really or not, or there are some ectopic malpositions or ectopic non-dilatable area is there or not.
I agree with the first point that you need to take, if you're using an NC, you would take from the distal reference there, and I was used with a 1:1 balloon. Otherwise, it's meaningless. If you use an undersized balloon, you're not going to get the feel of the lesion at all. All I'm saying that because we deferred a procedure for because of renal injury issues, I think we need to really limit our dye. Now the current recommendation is not the 2.5 times the dye. Is recommended the GFR is equal to the dye use. So if you have a GFR of 60, you're going to use a dye of 60 as well. So that is the current recommendation, and one of the ways we can minimize dye use in these cases is basically an IVUS, as we have already suggested, because that doesn't require it. And also, if you use a lot of stent boost facility, the stent boost is not as good as an IVUS, but gives us some clue how the lesion has behaved if you take stent boost in different angles.
Okay, let's see what the OCT shows now.
Okay, fine. You come back. You come back. You should tell no. One minute. Okay. Slow flow. Okay. Telephone and please. Okay. Please show the. Showing no. Okay. So this is the OCT after rota. Okay. person. Delaney. Okay. Vinayak,
Yeah, see that.
any comment from panelist?
Professor Rahman? Please unmute yourself. Yeah.
Yeah. It looks good, but there is a small, in the middle, there is some interval flap or something, what I'm seeing there. While you were just moving in the middle of the, like in the 4th millimeter or the 5th millimeter. Some sort of flap-like thing is coming out there, whether it is an artifact or, yeah, no, it's an artifact.
Artifact.
It's an artifact. Okay. So 1.5 bar you have taken, and the reference diameter is in and around, how much you have calculated there?
2.29. 3.
So it looks a smaller caliber. It's a luminal diameter, right?
Yeah.
Much more the luminal diameter. So 1.5, because you know the rotablation, the rotabar should be 0.6, not more than 0.6. It's better to take the rotabar, the ratio should be 0.6, because somebody takes 0.7 actually. Because the net luminal loss is more, you should take more bigger bar. So in this case, 1.5 bar has just polished the calcium well, and now just you can choose a stand with an appropriate length and the diameter also. Here, you know, here the IVUS is actually worse, better sometimes. Maybe the, you know, the eye satisfaction somewhere.
Personally, I feel I would still use a balloon to test the pliability of the lesion. As Professor Rahman has said, the calcium looks modified, but you do not know what the rotor does is to increase the pliability of a lesion. Unfortunately, unlike IVL, where you see definite cracks in the lesion, you know, you see which is very good detected by an OCT. And here, I think if you see a dissection with a rota, which is not very common, then obviously you need to adjust your stent size. But the pliability of the lesion, which is mainly the rota's effect, you would have to still test it out with a balloon inflation before you implant a stent. I wouldn't go directly to an implantation of a stent seeing just on this OCT.
Yeah, obviously the textbook approach is that after rota you'll have to do a full dilatation also.
Yeah,
you have to go for a dilatation, because whether the rota has worked or not, you can't understand only by imaging sometimes.
Yes.
So it's better to take it looks like a reference diameter 3. So you can take a 2.75 or 3 LC balloon and you can check it whether it's working or not.
There has been no disruption of the calcium. There has been an increase in the area, but as Dr. Ghosh mentioned, there is no disruption. So I think you need to have a balloon which can disrupt the plaque a little bit. Dr. Sahu, any comment? Dr. Sarath Kumar Sahu? Dr. Nirav Kumar, any comments?
Yeah, I agree with you, sir. I don't think enough debulking of calcium has been done. So it may require either we should do IVL, or we can repeat the up the rotabar. Or third option is we can try the balloon of 0.75 diameter of the vessel, so that we can see whether lesion is modifiable or not. whether we can put a stent or not. Otherwise, by OCT, by looking on the OCT, it look like it appeared that still enough calcium is there, particularly in some of the point.
Dr. Tripathi, what is it done?
So I think I'll go with a plain balloon, and there's no enough calcium there, and enough calcium has been modified. So I think there's no need to go for a oversized bar or a scoring balloon or a cutting balloon. Or I'll go straight to the balloon, and I think that's all. So any comment from panelist? So this is my decision. So you can give your opinion or suggestion.
No, I think the
in
best.
our scenario, Rota and IVL together would be a very, very expensive proposition, isn't it?
See, I think if I had an option, if the expense has not been if it's not a problem, then I would have gone with IVL. The reason is, see, IVL is safer option, and also this is it's more than 180-degree definite. It's not like it's a very minimal calcification. So it's quite good calcification. It's also with symmetrical. So if I had the choice, I would have gone with IVL. Of course, there is a slightly nodule. It's not really projecting into the lumen, but there is a slight nodule over there, for which, of course, I would have thought whether Rota would be a better option, because there is a possibility we may have some problems in dilating that area. But I think if you have gone this far, if you have used the Rota, then next let's go with a non-compliant balloon and dilate and see what it is, whether the bed is well prepared. And then we can decide whether to put in a stent or do something else.
Balloon, please. And see.
So which diameter you are going to take for balloon?
I'll take 3 millimeters. 3 into 8.
Good thing for the IVL in this case was also that it was a short lesion. So IVL would have been a good option as well. Lesion is short.
Yeah, one balloon would have done the job.
Yeah, you need to give the pulse only in the same segment again and again. You don't need to go up and down with the IVL to go for the shock on different areas, different lengths.
Yeah. Okay, you advise me to take a longer balloon or a shorter balloon?
That's the big question also, whether you take a long balloon or a short balloon.
12 or 8, anything okay?
If you have NC and 12 is okay. I think 12 is okay.
12 seems right, because if you take too shorter balloon, it'll ping pong. So that's one of the things. So you take a little longer balloon. 12 would be ideal, actually.
Okay. 6, 7, 8, 9, 10, 12. Okay. An injection, please. Please give. Go to high pressure.
It's slipping a bit. It's slipping. The balloon is slipping a bit.
1 minute. Please wait. Okay. Inflate, please. Slow. 6, 8, 10, 10, 12, 14.
Can you give a scene here? Can I give a scene here while in inflation? While in inflation, during inflation, please give a scene so that we can fix that whether the balloon has been uniformly expanded or not.
Okay. Still, I think the load
There's some
partition is not
wasting.
so.
Yeah.
Yeah, some waste is there. Okay, please take here. Please give here. Waiting. Okay. Injection, please.
In patient has symptoms because air bubbles are coming out in the stomach and the intestine.
To the tip of the guide wire. So, this control. Calcium lagunya. We have to take a scoring balloon. Please give here. Tightly in the 12, 14, 16. Bus. Injection, please. Okay, here give little. Yeah, please go ahead. 8, 10, 12, 14, 16, 18. That's fine. One injection, please. Give one injection. Okay. Here give injection, small injection. Here, please give 1 for 8, 10, 12, 14, 16, 18. Fine. So, okay. So I'll take an injection. So I have gone up to this 3 millimeter balloon. I have gone up to 18 atmospheres, 18, 20 atmospheres. So 1 NTG, 1 NG. There you go. What are you? Where did you talk? Can you talk? What are Okay, I'll talk to them. So let me put the wire in. So now I'll take injection, then I'll take an opinion whether to take a scoring or okay. 1 injection, please. Okay. So from panelist, your suggestion, please. So whether I'll go with scoring balloon or I'll go ahead with the stent. Okay. Dr. Dev. Hello.
You're muted, Dr. Dev. You're muted.
I will let you.
Dr. Dev, please unmute yourself. We can't hear you. You're muted. Yeah, see, I think I would have gone in with a stent. I think it's adequate. There is a little bit waste there, but that's I don't think we can improve on that now. It's just a slight over there, but no, I think we can go with the stent. What does the other panelists think? Dr. Ghosh, Dr. Rahman?
I would actually be sort of inclined to use a scoring balloon. I want that bed a little bit better because there was a lot of calcium on the IV on the OCT runs, and if I get in a stent and that area doesn't expand, the other part of the lesion is prepared. But if that area doesn't heal, You see, this was a 1:1 balloon. It was a 3 millimeter balloon. So a stent balloon will exactly do that. It will not expand more than what it is showing. The only thing is you can go into very high pressure inside the stent. That's the only thing. But I would be inclined to use a scoring balloon if it hasn't prepared my lesion well, and actually see whether the site is really nicely dilated before taking in a stent.
Yeah, but what the router hasn't been able to achieve, I'm not sure whether the scoring balloon will be able to do that, or should we go for
it often happens that sometimes if you have a calcium on one side of the artery, you will have an MLA at the expense of the other side. That is the usual strategy, but the problem with that is you have a very eccentric. So if the because the rotor did not engage the calcium in a 1:1, it just modified and shaved off the calcium. So to see the pliability of the lesion, the rotor and the OCT will not tell you a lot. I think just if a NC balloon hasn't dilated it very properly, I would be skeptical to put in a stent straight away. I would actually try to use an angiosculpt at least. Also, if you see that short balloon was ping-ponging a lot, whether it was actually catching the lesion or not, I mean, I'm a little wary of that. So I would take a little bit of an angiosculpt and 1:1 again, probably a 12 millimeter angiosculpt, and try it there again before moving on to a stent.
Any other panelists would like to opine?
Yeah, I think with Dr. Banerjee and Dr. Ghosh is telling it, okay, I love the scoring here also, but I think the operator's armamentarium is already in the battle, is getting exhausted. So it's better to take the stand and then later on do the post dilatation as much as we can, even by an OPN also or other way. I think the calcium has not been modified that much, but at least a bit modified. So the cracks, how much it is there, small, what I have told in the OCT previously, that there is some nodulish area is there. That one is actually is creating this sort of melon setting of the balloon there. So obviously it's not that much cracked, that's true. But I think the stent material itself and later on the post dilatation can make it possible to make the case shorter, and also stent can go there. That's the thing, and maybe a small focal part which can be managed later on after stenting. Also, that is possible.
Okay, so
left of the stent.
So Dr. Tripathi, now the decision is yours.
Okay, I think I'll take the stent. I'll take 3 millimeter into 33. Okay, 33 stent. Giants expedition.
333.
Which one you are taking, Prime or Expedition or the
Giants expedition?
Alpine expedition. Yeah, it is expandable. It's really very expandable.
Shubhro, just at this in the previous angiogram, just near that small diagonal upstairs, the lesion is not very has not yielded much. Just a discrete part of the lesion. If you see just after the balloon dilatation, just beyond, just around the small diagonal. There's a little bit of a tight focus. I might be catching the image on a dash in a systolic flame. That is also a possibility because it's a still image. There wasn't a play, but I thought there was a bit of a lesion which has not yielded. Just where the septal, where the diagonal, small diagonal takes off.
Yeah.
33 is okay, no? 33. Just before or after? That's okay.
You know, that's the problem with the calcification, especially for the focal calcification, and that's the problem when we have got the IVL. that when the better options are coming in, and then we are looking forward much more, and eyes are catching that one much more, because like when only the rota was there, then we used to go for the rota and we used to be happy that, yeah, we have cracked it, and we just go for stenting without thinking that much whether the crack is there, how much crack is there. Lots of things are happening now in calcification, to modify the calcification or something, to be much more meticulous. But that lots of time, like 5 years back or 10 years back, we have done so many stentings with underexpanded or malapose struts in the calcified segment.
Small. Okay. Little distal, huh? Distal take nahi. It's okay, no? Okay. One arrow view. Better, okay.
I think for the beginners, this is one point we have to make, that it's always better to prepare a bed rather than doing a lot of stuff after putting the stent in.
Right.
That is, the main recipe of stenting every time we have seen in the books. But the armamentarium was very few at that time.
No, but well expanded. Okay. The plate. One injection will take up to this 1 minute.
I think angiographically, the stent balloon has expanded well, and almost even on that focal part, which we were thinking that can create some problem.
NTG, please. NTG and one injection. Post-deltus balloon, please. One injection and post-deltus balloon, 3.5.
So now, Dr. Banerjee, Dr. Ghosh, that what you usually do in your common practice, that before post-dilation you want to go for an imaging, or after post-dilation you want to go for it?
In this case, definitely I would do it after I have done a post-dilatation. I would take an image to make sure that the apposition is well, because again, you would be every time you have to do a post-dilatation. Means post-dilatation, you have to see the stent apposition, isn't it?
Then there is a chance for twice you have to go for an image.
No, I wouldn't do it at this stage before the post-dilatation. I wouldn't do an OCT at this. I would do it only post-dilatation.
What balloon you are using now for post-dilatation, Dr. Tripathi?
Boost is not there. Excuse me, sir.
What balloon you are using for the post-dilatation?
3.5 NC balloon. 3.25 into 12, right? The sapphire balloon. Please go ahead. NC.
It's better not to expand the distal part of the stent, because already it is over.
Yeah,
so I agree. I agree.
Yeah.
In fact, I would use a stent boost at this stage to position it, or you use a DCM, just to do a CD, because already it was oversized.
Yeah.
And 12. Okay. Well, no. What is
Here as much as you can.
Can you do a cine while you're doing this part? It'll help us to see the expansion better. Or a stent boost.
Stent boost is there now.
The only problem of doing cine repeatedly is that your radiation.
Radiation. Yes.
Otherwise, it's so it makes operators' life a bit easy, like they can see it better. Yeah.
Okay, fine. You can give her dilatation or dilatation, please. Sorry. Okay, stop.
I think it's reasonably okay. And what about Dr. Banerjee is telling us the radiation, you know, that all the time while entering into a complex case, first thing I used to think that not more than 3 Guy or 3 gray, not more than 3 gray. I will be that much meticulous while doing this. But if I'm in trouble, deep trouble, forget about the radiation. Then at that time, the patient is in that problem, in such a problem that I used to forget about what is the radiation level is.
True.
I think you can take this precaution with a LED screen and everything and minimize the radiation. But again, this is not a very high radiation. It's not like a CTO where the real problems are.
Right.
Good actually.
Yeah, it looks good.
Would see the distal lesion. Distal edge you will see.
Edge, I think you need to see a little bit.
We'll see the distal edge. That is, I think, a breeze was there.
Yeah.
That I was afraid actually, not to balloon there at all.
Yeah, I agree, because it's after the first, it's after the large diagonal, relatively large diagonal, and the caliber of the LED would have actually decreased quite a bit from the proximal artery. And I would take at least an image on a different view rather than just this view, maybe an eleo-cranial.
We'll take OCT.
Yeah, OCT would clarify that.
We'll take OCT.
Yeah, OCT will clarify that. Even better. Yeah, agreed.
Guys, what do you think the OCT will show? Expansion proper, apposition proper?
Yeah,
I speculate a little bit.
No, I think the expansion shouldn't be a problem. I'm just a little bit concerned about the distal, just to make sure there's no dissection. Probably not. I don't think it's a dissection. There will be just a step up, but still, I think city maybe.
It didn't go up to that much to make a dissection, but overinflation is there. It's a stretched wall is there, and that one is like a shell, possibly.
But it's a distal one. Had it been a proximal, would have been less concerned. But if there's a dissection, if it's a distal, the distal part of the stent, then
gradually it will increase, and also, and we can see after the second chart, it will be. You'll see that more and more whitish thing is there. Yeah, it doesn't look.
Okay. What are you using?
There's a septal coming out from that.
Yeah. It may be a septal. That's why I'm saying another view might be helpful.
Yeah.
Great. Okay. 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 Sine, no. Sine. is not a contrast. I'm coming out. Automatic place. Automatic place with it. Please see the OCT, particularly the focus on the distal edge of the stent. Brother. Lot. Distal one. All pose. Distal is no dissection. Nothing required for that. No, okay, small dissection. Okay. So. Okay. Dr. Dev?
Yeah.
I think there is a small dissection, maybe a dissection distal to the stent. Yes. Probably doesn't need anything, I think. Just leave like that. So, what's the opinion of the panelists?
Yeah, it's a small tear in your shirt, so that one is okay because it is it is in the lower part of your shirt, so it's not going to create that much problem in by appearance and in future also.
Yeah, it's about it's not long, it's about less than 3 millimeter, I suppose.
Okay. Length of the tear. Okay. Okay. I'll come out the wire on final cine. That's it. Right. That's it. Okay. Okay. Right. Over. Okay. Right. So this is the final shot. Area of caudal and also PX cranial. So I am taking out the guiding catheter. So
Dr. Ghosh, at what stage of the dissection would you get worried and put another stent?
I think if it was a little bit more circumferential and more extensive, I would. The only danger is it's downstream. That's the only thing which I'm a little skeptical about. But I think it's a very small tear. I wouldn't really put in a second stent there at the moment. But I think you need to keep an eye on this patient. Would he use a 2B3A in these patients? Probably not.
No, I think another thing is, yeah, I was just going to say also that it's just intimal. It doesn't spread to the, to the media. There's no hematoma. Length is also, it's not, arc is also small. So I think we can leave that.
You know that a small sort of suspicion will just knock your brain all the time. At least this night, what will happen later on? Because sometimes even this sort of dissection are so much thrombogenic, much more. That is the most, the cruelmost thing that which you never expected in that way. In the middle of the night, patient started screaming that I have chest pain or something. That's the problem. And just not to face that one, better take a stand there overlapping and then just come out with a happy face. That's possible, but at the same time, again, longer the stand, overlapping the stand, also it's not good. So
I think the distal part of that section also has some disease, so you'll be really running after the normal segment, and there'll be no end to it then. I think it is better to leave it now alone and then see how it goes, rather than putting a stent right now. Dr. Nirav Kumar, any opinion from you?
Yeah, I agree. I agree with you, sir. I think we should observe the patient. That is important. It is less than 2 millimeter dissection is there, so better to observe. Unnecessary putting a stent and making it longer and longer will not solve the purpose.
Okay.
Dr. Banerjee, would you like to sum up?
Yeah, I think that was an excellent case, which showed a lot of things like, firstly, is in a calcified artery, what should be our approach? We had discussion with this. When should we go with a non-compliant balloon? When should we go with scoring or cutting? And when we think of more advanced technologies like rota and ablation. So in this case, we did a rota was done. The results were fine. We had a little bit of debate whether we should go with a higher bar or whether we should take a cutting balloon. But at the end, I think what it shows that, we can have different hunches, but exactly how probably if you have used a cutting balloon or a scoring balloon, in this case, the results would have been equally good or maybe better. We don't know. But I think what we achieved at the end with your non-compliant balloon, the results were fine. And I think another thing is, of course, we know that once we are dilating a stent, the distal end of the stent, at times we have to be very careful. We like it or not, at times we get a bit of dissection, but again, all dissections may not be that dangerous, but we have to decide. OCT is particularly valuable in such a situation. And if necessary, we have to go in and put in a stent, because a stitch in time would save 9 rather than leaving things to happen in the night.
Dr. Tripathi, we are very grateful that you showed a beautiful case, and we had a lot of discussion points on this case, and I think the outcome was very, very good. I would like to thank Professor Saidur Rahman Khan from Dhaka that he has joined and given his valuable inputs. Dr. Devashish Ghosh from Apollo Hospitals, Kolkata, and Dr. Nirav Kumar, and my co-moderator, Dr. Subra Banerjee. So I'll give you the final comments to make, Professor Tripathi, and then we'll finish this session.
Okay. So I think from this case, the learning may be, I think in most of the cases where moderate to severe, I think IVL is the choice, I think, what I feel, rather than rotablator. And I think adjunct to IVL may be ultra high pressure balloon inflation. So I think these two important. I think all are I think complementary to each other, like scoring balloon, cutting balloon, all other debulking devices. But whatever may be, my experience is, I think with IVL, I think results are very good. And, I think this is my opinion. Thank you. Thank you very much.
Okay, thank you very much. And again,
I want to thank Dr. Tripathi just to take a very real world case rather than an asymmetric one as a live case. So that's why I'm thanking him very much.
Okay, thank you.
Really warm thanks to the entire team of Care Hospital. And thank you very much. Hoping to see you again. So
okay,
we'll finish this session. Thank you very much.
Thank you.
Thank
you. Good night.
Thank you.
Thank you. I'm thanking him very much.
Hello,
হ্যাঁ হ্যাঁ জয়েন করছি। হ্যাঁ হ্যালো
We'll just wait for another couple of minutes, sir. Then we can start.
Yes. Expert panelist কারা জয়েন করেছে? ডক্টর অরুণ শ্রীনিবাস করেছেন?
হ্যাঁ, উনি এখনো করেননি, করছেন।
Can you hear me?
Yes, I can hear you.
Yeah. Good evening.
Yeah, so Dr. Nagamale sir has joined.
Okay.
Dr. Rajanak sir has joined. Dr.
Dr.
Sahu
Sahu
has
has joined.
So sir, I'm just giving 30-second countdown. Then after that, you can start. The first presentations can be done by Dr. Nagamale sir, then Dr. Rajanak sir.
Okay, okay, fine. Good evening. Welcome to ODISHA Live, Conquering Complex Coronaries. We just had a beautiful first session with a live case by Dr. Mahendra Tripathi from Care Hospital. Now we will have 5 case-based discussions, and we'll start off with expert panelists on names of Dr. P.K. Sahu, Dr. Arun Srinivas, Dr. Naga Malesh, UM, and Dr. Raja Nag. And I'll introduce our panelists first. Dr. Arun Srinivas is MD and DM from Mumbai, and he's done his pediatric fellowship in pediatric cardiology, fellowship in coronary interventions, and fellowship in peripheral vascular interventions, currently associated as Chief Interventional Cardiologist, Apollo BGH Hospitals, Mysore. Have many publications and won several prestigious awards. Welcome to the session, Dr. Arun Srinivas. Dr. Naga Malesh, who is also expert panelist along with the speaker. He is MD DNB Cardiology, FACC, FECC. He is a passionate teacher and an astute clinician. He successfully started the heart transplant program at MS Ramaiah Memorial Hospital, Bangalore in 2015 after having trained in heart failure, mechanical circulatory support, and cardiac transplant from Papworth Hospital, Cambridge, UK. He has more than 20 years of clinical experience in managing emergencies like acute myocardial infarction and chronic portal occlusions alike. Forte includes, but not limited to, left main bifurcation stenting, vein nerve disease, and restenosis, radial interventions, rotational atherectomy, FFR, and intravascular imaging. Welcome to our program, Dr. Nagamalesh. We also have with us, who will be joining soon, Dr. P.K. Sahu, Senior Consultant Cardiologist, Director, Interventional Cardiology at Apollo Hospital, Bhubaneswar, is also Adjunct Associate Professor of Cardiology, Apollo Health Education and Research Foundations, Chennai. Welcome, Dr. Sahu. We also have with us Dr. Raja Nag, the Senior Consultant Interventional Cardiologist at Apollo Multispeciality Hospitals from 2010. He is also having experience at working in different parts of India, like Vijayta Heart Hospital, Vijayawada, and also at Perambur. Dr. Nag did his MBBS and MD from Guwahati Medical College and completed his DNB in cardiology from Railway Hospital at Chennai. Dr. Nag has vast experience in interventional cardiology, and his interests are complex radial angioplasties, valvular interventions, CTOs, bifurcations, CRTD, and having a great expertise in imaging modalities like OCT and IBUS. Welcome, Dr. Nag. We have with us Dr. Saroj Kumar Sahu, who is MD DM from PGI Chandigarh and a very young and dynamic interventional cardiologist currently associated with All India Institute of Medical Sciences Hospital, Bhubaneswar, and consultant interventional cardiologist. And last but not the least, Dr. Dibya Ranjan Behra, who is MD DM interventional cardiologist, currently associated with AMRI Hospital, Bhubaneswar, a senior consultant and a young and promising cardiologist of ODISHA. After these introductions, I welcome our panelists, Dr. Arun Srinivas, Dr. Raja Nag, and the first topic will be discussed by Dr. Nagamalesh, UM. His topic is complex PCI-based discussion. Your talk will be for around 15 minutes, Dr. Nagamalesh. Thank you.
So my slides are seen?
Yes, it is visible and you are audible as well.
Okay. So I'll be presenting an interesting case. This elderly man, 89 years, who presented with heart failure and ACS. And when he came, his BP was low, so patient was intubated and he was put on standard ACS and heart failure therapy. And ECG shows significant ST depression in anterior leads. Echo showed global hypokinesia with severe RLU dysfunction. After initial stabilization, patient was taken off for coronary angiogram. So initially, basically, one second. So the CAG was done. It showed critical left main disease with proximal LAD and LCX disease, which is calcified vessels. So patient was put on ABP and stabilized. And the plan was, because patient was elderly, so we are planning to do angioplasty for this patient. So the plan was to do a rota, PTCA to left main, bifurcation stenting under IVUS guide. So this is what our plan. So this is the material we used. You can come back and discuss about this. So cyan blue and turn track wires are used. We used a 1.5 rotabler, and we period dilated with the 2.75 to 15 to LAD and 3.5 to 20 to LCX. And we used 3.5, 24 to LMCA to LCX stent, and another 3 into 38 to LMCA to LAD. So we used a post dilatation with 3.5 into 20 and 3.5 into 12 to LAD 3.5 into 8 and 3.5 into 12. So this is what we did basically. The post LMCA we did with a 4 into 18 non-compliant, and we used IVUS. So I'll just show you the how we. This is a very elderly person, so very high risk patient. So I can show you the next probably. Yeah. So I could not download all the images, so I will just show you whatever possible. So it is, so you can see the LCX is calcified from the LMCA. It is calcified, and also LAD it is not seen because it is more towards the LCX, because we intubated like that our guide to do the rota. This is the rota wire, so to the LCX. So first we did the rota ablation to LCX. It was very tight lesion. Initially very difficult to cross this lesion. So slowly able to, because our aim was to keep this patient hemodynamically stable, because LV dysfunction, elderly person with critical stenosis. So we are very careful ablating these patients. Then I did rota to left main to LAD. So this is a actually LCX is more calcified than LAD, so it is also calcified. So once we done a rota to both LAD and LCX, so we wired both vessels on the cyan blue, and once we wired this vessel, so our aim is to basically pre-stenting. We have done IVUS, so I could not show that. Once we done this, and here one step is missing. So we have taken a 3.5 into 20 millimeter stent to LCX, and we placed one more stent to the LAD. That step is missing here in my recording. So we deployed the LCX stent to LMCA, projecting into LMCA, basically like a mini crush, and the LAD stent was pulled back to LMCA. So both are deployed, and we crossed the wire and did a kissing balloon to both LCX and LAD. After this is the IVUS run. So we've done an IVUS to both vessels, except in the proximal, most of the stent was deployed well. And also this IVUS run to LAD was done. So this is the end result of this procedure. So this patient almost completed 1.5 years now. So we have done a check angio. It's also absolutely normal. There's no restenosis, and is doing well. So basically, very sick patients. So we have one more patient now with a similar problem, but is quite young person. So it's around 56 years with a EF of 20% and critical left main and LAD LCX. So this for the patient definitely benefit from this type of complex intervention. Otherwise, sending these patients for surgery, they may not come out of the ICU. So even after 1 year, is such a 89 years old man is absolutely normal now. Is doing very well now. Thank you.
Thank you, Dr. Nagamalesh, for this case. So I welcome Dr. Raja Nag, Dr. Saroj Sahu, Dr. Arun Srinivas to make their comments. Over to you, Dr. Nag.
Thank you, sir, for inviting me. So actually, the wonderful case and great case, complex, really complex case to do in an acute setting in an elderly patient. But only thing is, unfortunately, a lot of images were missing.
Yeah, correct.
He learned from the images.
Yeah.
And the end result was fantastic. So I hope you have done a very good job. But at the same time, for learning experience and for academic reasons, we need to preserve and upload good images so that we can learn from them. Other than that, I don't have anything to say. Only
What do you
thing
think
I
about
want to ask one question. I want to ask one question. Did you start with the rota from the word go, or did you try to pass a NC balloon and see how the lesion is? Because the patient presented to you with ACS and cardiogenic shock.
Yes, we tried first to pass the balloon. So it was very tight lesion. We could not, negotiate balloon. So that was initially, that's the reason we first took, even we wanted to at least do only ballooning to LAD, because, we are worried about, no reflow and all this because the EF was low. So once we did at least to LAD, we'll do balloon. That's what, we had an idea, or IVL, that was the idea. Actually, initially we kept IVL also standby because, we wanted to do as minimal as possible because EF was low, elderly person, your creatinine was little high. So that's the reason we thought IVL is the better. So we could not negotiate, because to do IVL, we thought we will first take a NC and negotiate and see whether we can negotiate before we open the IVL. So we could not negotiate. That's the reason we did rota. Basically, these images are stored. We are not able to open few of the images. So I don't know, I couldn't open. So then whatever the open, I just, downloaded. Okay.
Okay, Dr. Sahu, Saroj Sahu, any comments?
Yeah, good evening, sir. It's a nice presentation, and it's I have one doubt: should we do Lakeman bifurcations, stentings, so physical dysfunctions? Should we put all patients for IBP or like LBAD devices?
I didn't get you. So you're asking whether IABP or LVAD device?
Yes, sir. In severe LV dysfunction patients with LMC bifurcation lesions, should we
IABP, we used IABP. The best scenario is LVAD, but it'll become very expensive. So that's the reason we used IABP. That would have been best scenario, less risk, less stress for the operator. So but it's very expensive, almost costs 18 to 20 lakhs. So disposable. So that's the reason we used IABP. We kept.
How far into the left main were you, Dr. Nagamalesh, from the LCX? From LCX stent, how did you position it? How much into the left main?
I kept it around 5 millimeter into the left main. It's like a mini crush, yeah.
Mini crush.
Yeah.
Dr. Nag, would you agree with the bifurcation technique here, which was used by Dr. Nagamalesh?
He tried to do I would say, a kind of a modified mini crush. So it's fine as long as the results are good.
So we wanted to add minimalistic, because the patient was very sick. We wanted to as minimal as possible.
Bifurcation cannot be minimalistic, sir.
Yeah, no.
One thing we need to understand is like when we do a bifurcation in a left main, we cannot get away by doing minimal work.
Yeah, I know.
So I would prefer to do a DK crush when both the vessels are of the similar size. And if it is not in an acute setting, otherwise I would try to do the minimal in the sense that try to do a provisional stenting and get away with that and take the patient out of the ICU at least for one day and then do the rest.
I think DK crush in this scenario would be it'll be a little heavy for the patient, seeing the condition.
Yes.
I think the mini crush which is did was pretty okay. Provisional stenting to begin with, and then finishing the job maybe a couple of days later, that's another option as well. So I think overall you've done the cases very well. So thank you very much. We'll move on to our next presenter, Dr. Raja Nag. He's going to talk about shock the rock OCT guided IVL. Over to you, Dr. Nag.
So with your permission, I'll log off because I have one more program. Sorry. So
Sure. Okay, Dr. Nagamalesh. Thank you for joining ODISHA Live.
Thank you. Good evening, everyone. So this is a case which is a very complex PCI which I had done some time back. So the patient is a 51 years banker. Diabetic, hypertensive, and presented to me with STEMI. So on 4th of February, he presented with STEMI with elevated troponin, ejection fraction 45%, and stable hemodynamics. We decided to do the angiogram by the radial route, which is my default route. So this was the angiogram. This is the RCA. Looks calcified itself from the angiographic views in the distal part. This is the left system. You can see the L6 also has a critical lesion and the LAD with a major diagonal occluded. So this was the angiographic views. The patient was in severe chest discomfort. So these were the issues we had at hand. Patient with acute MI STEMI, thrombotic occlusion of D1 with subtotal occlusion of LAD, multivessel CAD, and calcified coronaries. So we plan to do it in a staged manner. In the presentation, I decided to do his culprit vessel of LAD diagonal first and then take it from there. So went ahead with the right radial route with the 5/6 slender sheet, 5/6 French slender sheet. EBU guide went ahead with 2 wires. And I like to do OCT more than IVAS. So I did OCT guided imaging for this patient to quantify the calcium. I was not sure from the angiography whether we would need any debulking techniques or not. So the first thing I did was to open up the diagonal. Did a balloon. The flow was restored. He was somewhat stabilized. And then I decided to do imaging of the LAD to see whether the calcium was more and whether it was more than 270 degrees calcium, which would need some form of debulking or cutting therapy. So if you see, my OCT catheter is not passing through. Then I understood there is something sinister more than the angiography, which is what is showing us. So when the OCT catheter did not pass through, I went ahead with the 210 across balloon, and this was how it opened. But it was not across the lesion, I can tell you. So then I went with a 2.5 12 NC balloon, which went through with great difficulty, but it was not, the lesion was not giving away. So finally, with very high pressures, it ruptured. So this time, I thought I should take more guide support and take a guidezilla. But before that, I tried putting a IVL balloon of 3.5, but which did not go through the lesion. So I decided to take a guidezilla support and take my IVL balloon. So this was the IVL of 312, so not 3.5, 312, which was just kept at the proximal segment of the lesion. And I decided to give the first shocks. So you can see the distal lesion has not crossed yet, and my guide is still backing out. So after the first shock, I was able to take the balloon across the lesion. And now I delivered all of my shocks in that lesion. And after that, I did OPN because the balloon was not fully opening, even the IVL balloon. So after this OPN, we decided to do the OCT now. Now that everything is settled, I decided to do the OCT. So this was the first OCT run, and this is the image which we have. So to save time, I will show you the still images. These are the cracks which have been made by the IVL and the OPN balloon. And you can see the cracks are well into the, up to the intima. You can see the cracks here. Some thrombus is also seen. And then I decided to do the stenting of the LA. Before that, I forgot to tell you, I finished the stenting of the diagonal before that, not before that. And because there was space in the ostium, I did not come right up across the LAD. So I decided to do the LAD stenting with the 334 regulating stent. Post-dilated it again nicely and did the OCT run. So this was the final OCT run. This is a 3D rendering of the image, which showed an expansion of around 90% with the area of 8.1. You can see very well where the lesion area, in the lesion area, the stent has opened up very well and the luminal gain was significant. So these are some still images which show wonderfully the pre-stenting and the post-stenting. Just after the IVL, you can see the luminal gain. And after the stenting, we see how much luminal gain was achieved after the stenting. So this was the final result. So to conclude, stage PCI, I did the stage PCI of LCX and RCA 1 day later. Patient was stable all throughout. RCA again required IVL therapy and discharged after 2 days. He was discharged after 2 days and hospital stay was uneventful. Just for the sake of completion, I'm showing this RCA stenting and the LCX. And this was the final result. Presently, he is on follow-up and he sent me photos from Mauritius. He's vacationing there at present. So the issues in such complex situations with primary PTCA is whether to do complete or incomplete revascularization in acute myocardial infarction. So the complete trial has given us the guidelines by saying that compared with culprit lesion only, a strategy of non-culprit lesion PCI with the goal of complete revascularization performed early during index hospitalization within 1 day or after discharge within 23 days confers similar benefit on major cardiovascular events. So these are some of the co-primary outcomes between only culprit vessel and total revascularization. So the biggest fear is like the more stents lead to more target lesion revascularization. So this graph clearly shows if you do complete revascularization, the risk of future target lesion revascularization or non-target lesion revascularization is higher if we do incomplete revascularization. So the summary and take home is multivessel disease is common in today's world, and whoever presents with STEMI also has diseases in other vessels. They require careful decision and staged treatment. If staging, we need to make sure that the culprit is treated first and then treat the symptomatic patient. Optimize the lesion bed and preparation where there is calcium, where there is need of any special debulking. Multivessel disease has higher propensity for calcification, and whatever we see in angiogram is not enough to tell us whether this calcium will need what kind of therapy in the form of angioscalp, cutting balloon, rota, or IVL. So multivessel PCI is appropriate for a large group of patients. Reflexive CABG referral is unwarranted. Careful assessment of patient anatomy, treatment plan is essential for optimal results. So the calcium in ACS may be challenging. Anticipation is important. OCT gives an excellent idea about the, not excellent, it gives the best idea about the excellent depth of calcium and is a wonderful tool in obtaining optimal stent deployment for better outcomes. So in my case, OCT also confirmed the safety of coronary IVL with no severe angiographic complications at the end of the procedure. OCT also have shown in trials that there are fractures not only circumferential but also longitudinal and in the parallel planes. So the MSA, area stenosis, and stent expansion outcomes were excellent regardless of calcium fracture. Visualization, whether we see it by OCT or not, after the calcium fracture, there is excellent area achievement and may represent a limitation of OCT to detect subtle microfractures or out-of-plane fractures, which have been shown in micro-CT in elegant studies. So in future, we will need better profile of IVL balloons, need longer IVL balloons with more energy capability. And cost is, of course, a hindrance at present. Thank you.
Thank you, Dr. Nag, for this excellent case. May I ask you a question on after the IVL, why did you use OPN balloon?
Yes, after the IVL, I was still not able, if you could see, my IVL balloon did not open in one eccentric part, in the inferior part, there was still a waste. So I decided to do a full preparation before taking in my stent. And even while doing the OCT, I could see that there was some eccentric lesion, kind of calcium nodule actually, which I wanted to crack. So after that OPN balloon, there was one point when it totally gave way, and we were happy to deploy the stent.
Yeah, because we normally use the OPN post dilatation for ISRs. So using two side by side. So this was one point. The other point is actually concern about the ostium of the diagonal, which was left alone. I mean, I think it's very uncommon that the ostium would be spared in that case. Do you think that you probably would need to do a FFR to see whether that diagonal ostium is adequate or not?
Angiographically, the ostium of the diagonal was disease-free, and there was sufficient space for me to land my stent, number one. Number two, it was a thrombotic occlusion on the diagonal. The diagonal lesion was very soft, sir. So with the first balloon, I could open up the diagonal and the flow was good. There was no thrombus. There was no significant lesion also. So I did the balloon and immediately deployed the stent in diagonal, which was not very difficult. So I also did the OCT run later through the LAD. And from the LAD, if you see the 3D rendering, I could see the ostium of the diagonal is visible. And that showed us that there is no significant disease in that area. So I think I could get away with that, but otherwise I would have gone with a bifurcation stenting.
Yeah, that would have been more complex in this particular case, an acute setting. So I think this is a good decision if you take. Dr. Saroj Sahu, do you have any questions to Dr. Nag?
Yeah, thank you, Dr. Nag. It's nice presentations. I have one doubt. Should we do all the angiographically calcified lesions before doing?
Your voice is not clear, sir. Please, I think some problem with your audio. I can't hear you clearly. I cannot understand your question.
Yeah, am I audible to you right now?
Yes.
Yes.
Yeah, it's a nice presentation. Thank you, Dr. Ras. I just want clarifications that should we do all angiographically calcified lesions? Patients should have to undergo intravascular imaging, like you did ISOCT.
So you are asking, your question is whether we should do imaging in all patients where we suspect calcium.
Yeah.
Yes, if possible,
where
yes.
Where you see angiographic calcium.
Angiographically, we
not only angiographic calcium. I have had cases on table where I could not take my balloon in. Then on the table, I had to call the patient party and counsel them that I need imaging. And if imaging shows significant calcium, we may need either a rota or a IVL. So IVL. If you want to do a good job and not let the patient come back later, then you need to have these tools, and provided if the patient can afford. I totally understand in our country, it is not very easy for people to afford such high-end therapy. But this is how it is in today's world. We see more calcium. 30% of patients who present with ACS have calcium in their arteries, whether in that ACS culprit artery or in other arteries. So these needs to be treated well. Otherwise, this will not give you good lumen gain or achievement of good stent area.
Thank you so much.
Thank you, sir. Thank you.
Yeah. So we'll proceed on to our next presenter. Dr. Saroj Sahu, would you want to present your case?
Yes, sir. My slides are visible to you, sir?
Yes, it is visible.
Yeah. So you can just make the slide on full screen, sir.
Just maximize your slides.
So only to maximize, sir.
Make it full screen, sir. Yes.
Yeah, good evening, sir. Today I'm going to briefly discuss about the use of FFR in particularly acute coronary syndrome patients. As you all know that FFR was most established among patients present with stable angioidas, and revascularization of non-infected arteries at time of acute microinfarctions, infections, which is very even very topic of debate in particular ACS patients. So in ACS patients, we have the categories of patients who have estimulation microinfarctions, NSTEMIs, and unstable angioidas. And FFR guidance recommendations, particularly in ACS patients, for ACS patients, NSTEMI or STEMI, FFR was not recommended for culprit lesions for obvious reason that patients have obvious thrombotic lesions. However, in patients with ACS and multivessel disease, they have other arterial lesions, the non-culprit arteries. We can do FFR to assess the physiological significance of the non-culprit arteries. As Dr. Ajay discussed, the complete revascularization trial, the complete trial that in ACS patients after doing primary PCIs in culprit lesions, you can assess the physiological significance of other territorial arteries to complete the revascularization process to get maximum benefits from the complete trial, complete trials. And it varies of intermediate lesions like 50 to 70% lesions in STM patients, particularly after doing primary PCIs. So FFR should be done in those kind of lesions of intermediate lesions. If the lesion was FFR is less than 0.8, we can do complete vascularizations. And if the lesion is more than 0.8, we should defer the interventions. I will discuss briefly about compare acute trial just presented in 2017. It's a randomized prospective trials designed to investigate validity of the current guidelines for complete versus infiltrated arteries in STL microinfarctions with multivessel disease. So it's a large kind of largest study is comprising around 885 patients of STEMI with multivessel.
Hello, sir. Sorry to interrupt, sir. Actually, your slide is not moving in the presentation. So you just stop share and then you share the screen, then the PPT. Select the screen. Don't select the PPT. Yes. Now you share the screen first. Then you select the. Click on the share screen. Yes, sir. Then select screen.
Yes, sir. Is it clear now?
Just move your slides a little bit and see whether it's moving or not.
Yes, sir. It is clear now, right now.
I can see only one slide, but can you move on the slides and see? Just scroll the slides. Yeah, it's moving now. Yeah. Okay.
Sir, is compare acute trial designs. They've included 85 patients of stable multivessel STEMI patients, out of which 295 patients who are undergone FFR-guided complete vascularizations, and 590 patients enrolled for infected arteries only and deferred PCS. So they are followed up for 30 days, 12 months, 24 months, and 36 months. And they've concluded that from FFR-guided revascularizations of non-infected arteries, they've reduced mass events like stretch, MI, and compared to the infected arteries only. So those STEMI patients, multivessel diseases, have non-culprit lesions have significant FFR, and they have complete vascularizations. they have significant reductions of mass events as compared to only infiltrated artery involvement. And complete revascularizations with patients with FFR-guided revascularizations have significant reduced mass events as compared to this infiltrated artery treatment only. So from compare acute trial, it was concluded FFR-guided complete revascularizations is safe and feasible in STEMI stable patients multivessel disease, and it reduced the risk of events compared to angio-guided IR only treatment strategies. And patients with FFR-guided treatments has 13% lower mass events, which resulted in 65% risk of reductions of mass at 1 year compared to patients undergoing angio-guided infiltrated arteries only treatments. So untreated FFR positive non-IR lesions are associated with 31% incidence of mass at 1 year. And this is a cost-effective reductions comparing the complete revascularizations versus IRA only treatments in different countries, mostly European and North American countries. They've showed significant reductions, cost reductions compared to IRA onlys. So patients who have undergone full revascularizations in index admissions or in subsequent admissions, they have reduced mass events in 1 year and reduced incidence of urgent revascularizations compared to IRA only artery interventions. And from the comparative trial, we conclude that complete revascularizations in STEMI patients with FFR guidance can result in lower incidence of mass events, lower cost burden to the patients and societies, and lower reduced number of re-interventions. And this is simple algorithms to management of patients for SCS. The patients presenting with SCS like STEMI or STEMI, if the culprit lesion is there, the FFR is not recommended. For non-culprit lesions, FFR is recommended. If FFR is less than equal to 8, so PCI was recommended. If those lesions having more than 0.8, which was not recommended, they should put on OMTs. So in stable patients, particularly intermediate lesions, like 50-70% lesions, FFR should be done. So the FFR should be less than 0.8. This will be undergone PCIs. If it had more than 0.8, this is put on optimal medical therapies. And in stable patients with severe lesions, particularly more than 90% stenosis, FFR is not recommended. Direct PCIs should be done. And those lesions with 70 to 80-90% of stenosis, FFR should be done in this kind of patient also in stable angina patients. If FFR is less than or equal to 0.8, PCI was recommended. If it is more than 0.8, OMT was recommended. Thank you.
Okay. Thank you, Dr. Sahu. We have with us Dr. Prasant Kumar Sahu as well, and Dr. Dibbaranjan Behera will be joining. So I asked Dr. Prasant Kumar Sahu to make some comments on this presentation. Please unmute yourself.
Yes, covered everything so far as the role of FFR in ACS patients. Definitely, it has got a good role, and definitely it is recommended that especially in ACS patients, to see which are the lesions which one should go for. So that is why FFR is definitely useful.
Dr. Nag, any comments? Okay, we'll move on to Dr. Prasant Kumar Sahu's presentation. I've just introduced you before. I'm just telling you again. He's consultant cardiologist and director of interventional cardiology at Apollo Hospital, Bhubaneswar. He's also adjunct associate professor of cardiology at Apollo Health Education and Research Foundation, Chennai. And he has pioneering work in coronary imaging with OCT in our part of the world. Over to you, Dr. Sahu. Please unmute yourself.
Are my slides visible, Dr. Binayak?
Yes.
Thank you very much for inviting me to give my talk. In fact, this will be a case-based learning on OCT in calcified lesions. Now, this is a very common problem that we see when we start trying to stent the calcified lesion. Ultimately, the stent doesn't open, and this is what happens exactly. And here the cardiologist, interventional cardiologist starts having problem about what to do, what not to do. Now that we have lithotripsy balloons, we can now naturally expand this, but sometimes you underestimate this calcium and all the problem starts. So this patient was after that dilated with the NC balloon, in fact, and then you can see how it has opened up, but it is not very satisfactory because you can see it is just 1.52 millimeters square. So the OCT shows a very poor result so far as because it was a very calcific lesion. And then the next thing that was happening when you use calcified lesion, malapposition and under expansion are very common because there may be stent thrombosis, and under expansion can cause restenosis. And even you can sometimes do an over-dilatation, and as a result, that may be a dissection or a perforation or no reflow. So these are certain issues we can avoid by using an OCT. Now, if you have to see why we need an OCT looking beyond angiograms, calcium detection on a coronary angiogram is only 38%, but an OCT it is 73%. The severity are almost equivalent. But we cannot identify deep superficial nodular calcium based on a coronary angiogram. And most importantly, we have the calcium score, which has got an algorithm which we can use to, based on the distribution and the thickness, based on which we can decide our strategy. Now, imaging has definitely made a great difference. Now, we basically follow 3 steps while doing OCT and calcific lesions. We see the site of calcium, the extent of calcium, and the quantification of calcium. If you have to see the step 1, you see whether it's a superficial calcium, it's a deep calcium, or a nodular calcium, because all these 3 subsets, they need different types of intervention. The next is see the extent of calcium. Is it eccentric or is it concentric? Possibly in a concentric calcium, your strategy will be different. And as an eccentric calcium, as you see in this diagram, your strategy will be different. Now, the step 3 is to quantify the calcium. It is very easy to remember that it should be the more than 5 millimeter in length, more than 50% of this thing arc, or if it is more than 0.5 millimeter in thickness, then this is the calcium which needs real debulking and should be done. So these are the 3 steps how we approach a case of calcified lesion in a coronary artery. Now, deep calcium is something which is that is the presence of a thick fibrotic cap is there, and there is a non-luminal, and these are the cases where we have problems, and in fact we try to see what can be done best in these. Now, this is known to every one of us that we do a scoring based on the calcium arc, where we give it 2 points for the calcium arc more than 273 points, length more than 1 or 2 points, thickness more than 0.5, 1 point. So these are the basic criteria of OCT. Based on 1 or 2 points, 3 to 5 points, we choose whether we do a rotablation or a lithotripsy or a high pressure balloons. Now, for coming to the first case, you see this is a TMT positive patient and a 62 years male, a modified reformed smoker, hypertensive diabetic, not much of calcium is seen. And as you see this part, you can see definitely the diagonal and the LED looks very simple. But when an OCT was done, as I'll go through it very fast, you can see that there was good chunk of calcium over here. You can see the chunk of calcium over here, which is almost a deep calcium. You can see a fibrocalcific plaque, and then here is the calcium. You can see the calcium over here quite deep inside. So this gives us an idea that we have to start debulking these cases. Now, this is what was done. That if you see analyze the OCT findings, you'll try to see that at the various parts, you can see how the calcium looks like. If I draw the diagrams of the lesion at various parts, you can see there is a chunk of calcium, and it is quite this thing that is based on that. What I did first was to use a cutting balloon. In fact, you can see also the calcium in the angiographic view also can be seen. After the cutting balloon, NC balloon was a high pressure balloon was used, and then a stent was given. In fact, it was easy to do this case, in fact, because the calcium chunk was not very high, and the diagonal showed some poor flow after that. And this is the final result where you can see a TME1 to TME2 flow in the diagonal. And this was case done in 2020, where you can see that the flow is very good and the stent is well opposed. Now, But when the OCT was done, what was seen was that this part of the stent has not expanded properly. So this gives, although the angiographically we see a very good result, but what you see that the stent has not expanded, and there is an area that we have to work. And so that is why we have to take a much larger balloon and start dilating this portion so that the unopposed portion do get opposed. And that is what was done. And in fact, this was further dilatation and port was done. This segment was dilated. And finally, port was also done to this segment, and the result was good. So you see, this is the pre and the post, where you can see how the stent has expanded. So possibly you would have left this patient if you wouldn't have done an OCT, and then we would have landed up in problem. And the most common problem would be a subacute stent thrombosis. This is the final result where you see everything is going on well. The stent has expanded well and opposed well. So it shows that we can, even with simple balloons, the cutting balloon and OPN balloon, one can go to very high pressure. Now, there are certain uncrossable calcific lesions. For example, you see this 46-year-old male who has got a strongly positive TMT, a very tight lesion. In fact, after the wire root cross, and you can see a tram track calcium over here. In fact, if you try to put it, this will come on uncrossable lesion. When you start selecting directly for a rotablation or an orbital atherectomy. Of the orbital atherectomy is not available to us, the next thing was to do a rotablation. In fact, a 1.5 burr was used, and the rotablation was done, and we could see that some debulking has taken place. And based on the debulking, if you see the OCT after the debulking, you can see that there has been some debulking done, but it is not a very satisfactory one, after which this is the OCT post-rota, where you can see that, this is the OCT post-rota, where you can see the lumen size is increased, but definitely further larger post-NC balloon dilatation would yield it more, and in fact it did when we went to very high pressure with a non-compliant balloon, and it was done well. And this is a post-NC balloon. You can see the cracks over here in the calcium, which I'll try to go through fast. Here you can see the cracks that has occurred, and then the lumen area has also increased. Then based on that, the OCT analysis, one can clearly see that we have made a good lumen, and now we can stent it, and that was a final result post-stenting and post-port. So there are cases where it is an uncrossable lesion, where you have to start using this thing, rotablation, to debulk the calcium. Now this is a final OCT picture, and you can see that the stent is quite well opposed, although there is some areas where there should have been some better expansion. And in fact, if you try to analyze it, you can see that after high pressure dilatation, this stent has very nicely opposed, and the results are good. The third case that will present is beyond balloons, that is beyond balloons and beyond atherectomy, IVL is there. And these are such cases where you can see dense calcium, deep calcium, looks very deceptive. In fact, this is an angio of a young guy. And in fact, we had also a calcium in this thing that is circumflex, where you can see a tandem lesion, which is very calcific, and they were ectatic, it was calcific, and this is what you see. So the next thing that was supposed to be done was, you can see the OCT images of this thing, and you can see how deep calcium is there in these cases. You can see very clearly the deep calcium, and I'll show you the various sections of the images over here, where you can clearly see how deep the calcium is. There is a superficial fibrous layer, and there is a deep calcium, and you can see the lumen area, how less it is compared to the proximal, which is 7.02, and the distal, which is 5.32. So intravascular lithotripsy was selected in this patient because if you see the calcium quantification, the angle arc was more than 180 degrees, the thickness was more than 0.5 millimeter, and the length was more than 5. So to give it a point, it was 4, and for a 4 score, definitely one would first like to go for a lithotripsy balloon. So this is what was done. It fell in within 3 to 5 points. So if you go by the algorithm, you start using a lithotripsy balloon. So a Sock-Pips IVL balloon was used, a 4x12, and all the 80 pulses were delivered in the circumflex itself. So this is what it was, the post IVL angio, where you can see a lot of dissections have occurred. And then this is the post IVL OCT, just to show that how the area has been debulked. And here you can see very clearly that the area has already given away, And the calcium, there are a lot of dissections also. And the next point was to use the calcium fractures, as I showed you in the previous this thing. And most importantly, what you see is that the luminal area from 2.8, it has become to 6.9. So these balloons do work very good wherever the calcium score is very high, where you have to work. So have a good preparation of the bed. Now you can see the 3 cuts that have been done very nicely. And then it was after dilatation with a 4 millimeter NC balloon, a 4 into 32 synergy was used. In fact, this was the final result you can see. And this is just to show you that with this Sapphire 412 balloon, a pot was done. And this is the final result, which you see in the circumflex. So definitely this is a pre and the post. You can see possibly these lesions cannot be tackled with the rota, because rota will not debulk the deep calcium. And definitely your OP and NC may be problematic because you might rupture the vessel. And so one would like to go for an IVL in this case. So this is a post-stenting OCT, which clearly shows you that it is very well opposed and well expanded. And this is just to show the stent expansion at the end of the case, which has been 10.62 and approximately 13.54 and distally 10.54. So definitely the results are good and the patient has been doing well. So when to use lithotripsy, definitely the question is that primary IVL therapy has to be given when you have a superficial, a very deep calcium, very calcific, because if you do not put could do a good bed preparation, you might land up like this, and then again you might have to do a tertiary IVL. So calcium is like the unseen enemy and is always the most fearsome. So it is like this thing iceberg that is there. So it is better to see what is happening, and the best way to image it is the OCT. In fact, it is the OCT is much better than the IVS in evaluating the calcium and then putting it into the algorithm and then deciding what will be the strategy to be done next. So calcium coronaries in coronaries, as I told you, is the unseen enemy. Thank you very much for the patient hearing.
Thank you, Dr. Prasant Sahu, for this wonderful presentation. May I ask Dr. Raja Nag to give some comments and have any questions? I see Dr. Dibya Ranjan Behra. Dr. Behra, do you have any questions for Dr.
Good evening,
Sahu?
sir, and good evening, PK Sahu, sir. So it
Yes,
was always it is always nice and very much lauding to hear Sahu sir particularly. And I remember from my DM days we organized CSI at Kochi. Sir was one of the speakers there. So I think it is a very very lucid and very nice demonstration of exactly how to deal with calcium, whether it is deep-seated or whether it is interluminal, what is the calcium score, how you score it. And I always ask that one question, sir. It is always when you prefer OCT, but OCT versus IVAS, is there any preferential setting where you prefer? Suppose you have both the gadgets. Many people are not that lucky, but
yes.
But can you?
Yes. I am lucky to have both the gadgets. In fact,
yes.
supposing
Yes.
when it is a left pen case, I always use an IVAS, number one. But if it is a non-left pen lesion, I like to do an OCT, especially in a calcific lesion, because you see the quantification of calcium on an IVAS is not to the great extent what is possible in OCT. Second, we have algorithms for the OCT. We do not have any algorithms for the IV of this thing that is IVAS. But after the HD IVAS, which I also have in my lab, I have been comparing cases with HD IVAS and also OCT. The images are comparable, but still then you have to use a lot of imagination. The learning curve is much high. So OCT might actually give you much better picture so far as calcium is concerned.
And one more question for calcific nodules. What is your, because that is the most
challenging,
dangerous demon. That
See,
is, so what is your
what
strategy?
I suggest is that if you have a calcific nodule, sometimes none of the therapies work, but only if your rota has got a bias towards a calcific nodule, if you try and bias your rota but towards a calcific nodule, possibly you can do. So here, these are cases where you have to do a rota along with an IVL. Possibly, I would prefer that way. Or a rota with a high pressure OP and NC balloon has to be used. But definitely, if your rota bar biases towards that calcific nodule, you can tip it and you can do better job.
But that bias is under our control, or
it is not under our control.
Exactly.
Invariably, the rota has got a bias towards the nodule. You have seen it tries to, because that is the toughest part. So the diamond chips usually go towards
exactly.
that is the nodule.
Dr. Sahu,
yes.
While you're using the rota bar, it's usually for the superficial calcium to make way for it.
Yes.
We don't really fracture the calcium, which the
Yes.
IVL does very well, but it is meant for the deep calcium. So after a rota, how many cases have you seen that where you do have to do both rota and IVL? Or do you do just rota and then follow it up with an OPN balloon or a NC balloon?
See, if you see the cost of a rota followed by an IVL, it becomes too taxing for the patient. In fact, I've only used one case where I've done a rotatripsy, which I did. It was a very resistant case, which I had to do. Or else, usually I take what I do usually, I take an IVUS and I upsize the burr according to it. So 1:1 sizing I do. Then I go with it so that my burr chips the calcium very well. Then I usually use, first I try with a plain NC balloon. Sometimes most of the time I succeed because there are high pressure balloons which are available for other Terumo companies which can go to very high pressure. But of course, if this thing high pressure balloon doesn't work, you have to take an OPN NC, which is also an equally costly item. That's the whole thing. But in fact, they do well. In my practice, I've seen that after doing a rota, chipping the calcium, one can easily go with a high pressure balloon and do your job and complete it.
Yeah, I think the rota, what it does is actually shaves the calcium. It doesn't fracture. So you obviously need a device which will have to fracture the calcium to make the stent go in properly and expand properly. So, but while you're doing IVL, do you need to do a post-dilatation, or sorry, a dilatation of the balloon in there?
See,
you do a proper IVL?
See, once you do a proper IVL, sometimes if you try to put the stent directly, you will see the stent may not expand. There are some areas because the IVL you might have missed. So normally in my practice, after I do an IVL, I put an NC balloon and also go to high pressure dilatation. Then in fact, in between do an OCT and then decide my strategy. But of course, you can directly after an IVL, you can go with the stent also because you have definitely debulked it very well. If you're happy with the images, you can go ahead.
Another question, Dr. Sahu, what about cases where you have renal compromise? I mean, you have some limitations of using the OCT. So at what point of time would you use the OCT if you have to use it, if you have limited use of that OCT in renal compromised patients?
Renal compromised patient, definitely IVUS would be the imaging of choice, number one. Now, because most of these patients of this thing that is renal failure, they have very chunks of calcium. That is what we see. In fact, when I was working in Japan, I was seeing that most of the patients are renal this thing, but they all used to do with IVUS. In fact, IVUS is a good imaging modality in these patients where you don't use contrast much and you can escape. And if you have to do this thing that is OCT in a renal patient, do a pre-IVUS, pre-OCT. That is more important than your post-OCT. That is what I personally feel.
You can get away with IVUS later on. Post,
yes.
You can get away with IVUS.
Yes.
Yeah. Okay. Thank you very much, Dr. Sahu. I think we'll have our last presenter, Dr. Dibyaranjan Tehra, and he needs no introduction. He's a MD, interventional cardiologist, currently associated with AMRI Hospital, a senior consultant, and a very young and promising cardiologist of ODISHA. We are very proud of you, Dr. Tehra. So please present your case.
Yes, sir. Thank you. Sir. Thank you very much. I'm sharing my screen. Is it visible, sir?
Yes, we can see it. Just maximize the slides.
Yeah. Now is it visible?
Yeah.
So it is a case of a left main trifurcation PCI. I'll go with my case. So the case summary is a 77-year-old male who presented with that history of cold antral MI and PCI to LAD already done in 2004. in some remote hospital, and LVF is 40% at the time of presentation to us, and there is on echo there is hypokinesia at the LED territory, and this patient actually presented with complete heart block. So both with this background, so while putting the TPI, and is diabetic also. So once I put the TPI, I also did the angio at that time, and this is the lesion. This is the angio. You can see that left main is quite long. It is dividing into 3 major branches: LAD, circumflex, and ramus. And you can see that the stent is visible in the LAD. It is diffuse. ISR is there. Ramus is very good branch, and there is a stenotic point here, almost 85% stenosis. L6 looks okay, so we'll take other views. Left main also distally 50% stenosis. So this is the LAD lesion. You see that. So this is a stent, instant restenosis, and beyond also that there is stenosis. And this is the right coronary artery. It has also a stenosis type A lesion, though not very difficult to do. So at this point, patient is in complete heart block, triple vessel disease. Though he presented primarily with complete heart block, troponin T is mildly elevated. So what is the plan? So actually, at that point, we consulted the surgeons also to whether the patient will need CABG, and we put either a epicardial stent, epicardial lead for the pacemaker. But somehow the patient and surgeons both denied, and they told to go ahead with permanent pacemaker implantation followed by PTC, multivessel PTC. So that's what we do. We have implanted a permanent pacemaker, and after 3 months, we call the patient for PTC. And this is the angiogram. So here, the point is the LAD, this left main is dividing into 3 major branches, and the LAD is diffuse disease with ISR, and the LAD is also hypokinetic. But at the same time, the circumflex looks good, the angulation of the circumflex looks good, and the ramus is a bit different. So here I have chosen a strategy that I'll go with bifurcation for LAD and ramus, and after that I'll do on the basis of imaging. I'll see whether circumflex is compromised or not. If circumflex is compromised, that can be provisional heart stent to the circumflex, and so this is the plan. With that plan I got, and also I decided that I'll use the ramus, which is good vessel, as the main branch, and use the LAD stent as a side branch. So as you all know, so this is the bifurcation scenario. There is no clear-cut guideline for the trifurcation scenario, and the trifurcation, depending upon the different branches, branch 1, branch 2, branch 3, whether this is a left main type of trifurcation or L6 type of trifurcation, or it is a ramus type of trifurcation. So depending upon this, we can have different strategies. We can do only one stenting and pot and come out, or we can stent 2 vessels, any combination, or 3 vessels, depending upon your imaging. So with that, I weared both LAD and ramus. Then just dilated the ISR with a 2 mm NC balloon. After that, I did the IVUS of the LAD, and this is the IVUS. So there is diffuse disease. You can see that distally there is also the luminary is very more, and there is a large plaque you can see here. And so from here the stent, yeah, this is the diffuse instant restenosis, you can see. So it is almost 2004 and 2021 we did it. It's almost 17 years. And towards the proximal, also this you can see that there is some calcium and LAD, and this is the ostium of ramus, as well as after that we will see the ostium of the circumflex. And the left main circumflex. So the circumflex ostium is digestly now this is into the left main, and left main have also plaque around 40 to 50%. So this is the measurements. You can see that this is the distal LAD. This is the instant restenosis part, and this is the left main, and this is actually the left main. So for the diffuse ISR, I have chosen this cotton balloon. So I have taken a cotton balloon 2.5 into 10 millimeter and did dilatation across the stent, across the ISR, till the ostium, because already ostium has some calcium also, some eccentric calcium. So this is the angiogram just after the cotton balloon dilatation. You can see this part also there is disease. So we have planned to stent up to this area, up to the distal. So first I put a 2.5 into 32 millimeter drug-eluting stent and dilated at 11 to 12 atmosphere. Then another stent is put. As I've already discussed that I am treating LAD as a side branch. So my strategy will be a decay cross technique. So I have just adjusted the stent so that it will just that one balloon across the left main to ramus, and just 1 to 2 struts will be protruding at the left LAD ostium. So that I can do a nano cross type of decay cross. So this is the LAD stent being deployed, and after that I have taken out the wire from LAD and crossed this LAD stent in the left main. Then ramus is wired and pre-dilated. Then LAD is rewired. And this is the angiogram just after the stenting. LAD stent is post-dilated with 2.75 followed by 3.5 balloon. And then from left main to the ramus, one stent, 3 into 30 millimeter drug-eluting stent, and deployed at high atmosphere. But you can see that the lesion has not given away even after the stenting. So then we have done the fast pot with 4.5 into 12 millimeter balloon, and after that LAD is again rewired. So this is the fast pot. Then to open the struts of the LAD, 1.25 into 10 meter balloon we have used. After that, this ramus part is post-dilated with highest NC balloon, and it was yielded. You can see that lesion has yielded. Then the simultaneous kissing balloon dilatation was done, putting a 3 balloon into the ramus and 3 balloon across the LAD. Then we did their second part, 4.5 into 12 millimeter balloon into the left main. So this is the result after that. Then I did IVUS from both the vessels, from the ramus as well as the LAD. This is the IVUS from the ramus. So we can see that stent edge is clearly visible good. There is no dissection. The apposition looks good. This is the tighter part, but it has opened well. So this is towards the proximal part. This is into the left. So in the longitudinal image, you can see that the lumen area looks good. So this is the ramus, minimum lumen area is 5.4. And this is the POC. Here the area is also good, around 12.6. Then this is the IVUS from the LAD to the left main. Pull back. So the stent edge looks good. So this is nicely approached stent. No dissection. In the interest of time, I am just. This is towards the proximal end, and this is the circumflex ostium. This is the ramus ostium. And this is into left. And here also in the longitudinal image, you can see that the luminal area and luminal gain is good. So this is the distal LAD, the area we got around 4.0 millimeter square, and towards the proximal part is 5.59. The POC is 10.78 and at left main is 10.8. So this is the final result. So as the circumflex is good, it has not been, the ostium looks good, it has not been pinched either angiographically or by IVUS. And so we have decided to let. And RC is also done at the same sitting. Total contrast is used less than 250 ml because we have used IVUS most of the time. So the patient is doing well, more than 1 year of follow-up. Thank you.
Thank you so much, Dr. Behera. I must congratulate the surgeon first who refused the case. Otherwise, we wouldn't be able to see such a wonderful, skilled presentation. So that was a very good presentation. Dr. Prasant Kumar Sahu, I would like to invite you for some comments in this case first.
Yes, I would like to know what was the, you went through the radial route?
Yes, sir.
Divya?
Yes, sir.
And what was the guiding catheter that you used?
7F. 7F XP.
Yes, doing a trifurcation of the 7F is actually a very difficult job. Because if you see the literature, they always
8F.
recommend 8F or take both punctures and take 2 guiding catheters. That is, in fact, whatever trifurcations I've done, I've always gone through both the groins, and because it's very difficult to do a tracing with 7F.
Yeah. Sir, actually, I prepared the groin and took one puncture from the femoral root, but at the end, it was not required. I already prepared one catheter, extra catheter for tracing, but not
Kissing is literally impossible. You can do a kissing with this thing.
Yeah. Tracing is not possible.
Tracing is not possible.
Not possible. Yeah.
So always, I would say take a 6-French or go through radial and femoral and then do it. But the case has been very well done, in fact.
Nag, would you make some comments, please? Raja Nag. Saroj Sahu, if you're around, if you want to make some comments, please unmute yourself. Okay, I think they're not present. So thank you so much again, Prasanto and Dibya, for your excellent presentations. And we are very proud that we could do a ODISHA live for the last 2 days. We had very, very good cases, 2 cases from one from Apollo Hospital where Prasanto is there, and one from Care Hospital. And we had some excellent talks. Today's 2 talks by Prasanto and Dibya were excellent. So I congratulate all the speakers and would like to thank the panelists, Dr. Naga Malesh, Dr. Raja Nag, Dr. P.K. Sahu, and our presenters, Dr. Sarojma Sahu and Dr. Dibyaranjan Behra. So we'll hope to have some offline conferences now in the future, and hoping to see you again very soon. So have a good day. Good night.
Thank you, sir. Thank you very much.
Okay.
Thank you. Goodbye, sir.
Thank you.